We're at the International Conference with Jonathan Mermin, who is with the International, the CDC's HIV/AIDS program on prevention. The conference here has been so much on the biomedical and behavioral, what we've learned. Now we have to deploy that and impress the governments and people to use that information to do what we need to do. Can you pick it up from there?
Sure. Well, thank you, Fred, for inviting me to talk with you today. It is an exciting and a difficult time for HIV prevention in the United States. It's exciting because we have a new national HIV/AIDS strategy that is a product of the work of many different parts of the U.S. government and stakeholders, and it sets a framework for all of the partners to work together towards the common goal of HIV prevention and helping people with HIV live longer, healthier lives. It's a difficult time because the economic situation, both in the United States and throughout the world, is causing budget cuts for HIV-specific programs, budget cuts in public health in general, and difficulties for a lot of the social programs that help support HIV prevention indirectly. At the conference, there's some information that's been very encouraging. One study has recently showed that a vaginal microbicide with tenofovir, an antiretroviral therapy agent, reduced acquisition among women of HIV by 39%. And that is another potential intervention that we will be able to use in the future to add to our toolkit for HIV prevention. And it is one that is in the power of women, which is an important opportunity for all women throughout the world, including in the United States. At the same time, we are still living in a world where the total number of people with HIV is growing every day. And in the United States, we estimate that there are about 40,000 new people living with HIV every year, about 56,000 new infections, and about 16,000 to 18,000 deaths. So that leaves us with 40,000 new people living with HIV. In some ways, a tremendous success story, because access to care and to antiretroviral therapy has historically been extremely good in the United States. Now, we are in a difficult time. There are some jurisdictions that now have waiting lists for ADAP. Some people, because of their social situation, economic situation, are finding it harder to actually access either prevention or care services. And a lot of the community-based organizations and state and local health departments that we've normally relied on to be the implementing arms of the public health infrastructure in the United States are now facing a crisis. And their crisis results in having to prioritize what interventions are going to be most effective at having the major impact. That's always been an issue, but at this point it's a critical issue. So I believe the National HIV/AIDS strategy lays the groundwork for us to see some ways for the future. One is it asks us at CDC to make sure that our resources are prioritized where and to whom are most likely to acquire HIV infection. So that means making sure that the states and the cities or rural areas within states that are most affected by HIV have the resources commensurate with their epidemic. It also means that people of certain racial and ethnic groups who are disproportionately affected by HIV also have an appropriate amount of resources for HIV-specific prevention activities in their population. So African Americans, who are 8 times more likely to have HIV than white people, or Latinos, who are 3 times more likely to have HIV than white people, get services to them to help reduce the risk of getting HIV. It also means that we have to provide our resources appropriately to different risk groups. So we've recently presented information that men who have sex with men are over 50 times more likely to have HIV in the United States than other men and women. That's an extraordinary disparity. Injection drug users are also more likely to have HIV. And in a poster presented by one of my colleagues at CDC with some collaborators throughout the United States this week at the conference, We've seen that certain inner cities in the United States have an epidemic among heterosexuals that results in about 2% of them being positive for HIV infection. And those are heterosexuals who do not have a history of using injection drugs or being involved in commercial sex work. So there's an epidemic that's being driven in these populations primarily because HIV prevention cannot be addressed without looking at the environment and social context in which people live. So as a public health agency, CDC is looking at the bigger picture and trying to address where we put our resources and also what interventions we choose to support. So it's important that if people want to be able to prevent HIV, that we set up an enabling environment for HIV prevention. That would include comprehensive sexual education in schools. It would include condom availability, so it's easy to avoid HIV, and it's easy for people with HIV to avoid transmission. It also includes some biomedical interventions, like making sure that people with HIV meet the ethical imperative to have the opportunity to take antiretroviral therapy for their own health, but also have the opportunity to reduce the chance that they're going to be transmitting HIV to others by having an undetectable viral load.
Community viral load, lower that community viral load. Is there any other areas that, I understand that you're wanting to take the finite resources, and I'm sure it takes considerable amounts in the bigger cities. Is there a way to develop, or are there models or programs that have been developed that are less expensive, that would be replicable in small towns, and where they're, maybe they want to do something, but they don't have it. They need some money or some direction. Is there some of that kind of programming available?
Well, we are looking closely at how we distribute our resources and how we choose the interventions that we're encouraging our grantees and our colleagues to use. I think the world out there has effective and exciting examples of what we can do.
Right.
Innovation is happening all around us, and we need to be able to learn from that. So I frequently go on site visits to different cities and areas throughout the United States and learn from my colleagues who are on the ground providing services. And they often adapt to difficult situations very creatively, and some of those solutions can be shared with others. Also, sometimes partners will raise obstacles that they don't know how to overcome, and sometimes we at CDC can either find examples in other areas or do some research or help support a pilot program where we learn how to do things better within that context.
Especially with less money.
Especially with less money.
Yeah.
In addition, HIV prevention does cost money, and it takes human resources, and it's hard work, but it is a cost-effective public health measure. The average lifetime cost of medical care alone for someone with HIV in the United States is $356,000. So even good HIV prevention can be cost-saving to the healthcare system, but it often takes the input of resources in the beginning to be able to make a difference. You have to buy your condoms and set up a structure to be able to distribute them openly. You have to be able to provide antiretroviral therapy to people and the healthcare infrastructure around that, so that people can both access antiretroviral therapy, adhere to their therapy, and stay linked to care and prevention services, even when the world around many of our folks with HIV is quite chaotic.
It looks like we might have some sort of a cure or therapeutic vaccine or something in maybe in the next 10 years. That's my hope. Maybe I'm just overly optimistic. But if that were the case, then this paradigm of lifetime of therapy is really not the way it seems at this point. Because you look at people that are 20 years old, that you're looking at something, saying, is this person going to be around off the system for 70 years? Well, hopefully not. Hopefully that person will not be on treatment for 10 or 15 or maybe 20 years, and then there'll be this paradigm that will take place that will offer us all an opportunity at a vaccine, a therapeutic vaccine or something. That's my hope. Maybe I'm overly optimistic.
Right. Well, I think the reason that we can work in HIV for over 20 years is because we are hopeful.
We've got it. And we had a win with the Capricit results. That was a real win, and the applauds were just palatable. It was just wonderful.
I agree, and I think it also provides us with an opportunity to merge biomedical interventions that have been proven to be effective, behavioral interventions which are proven to be effective, and structural interventions that set an enabling environment so that it's easier for people to avoid HIV and avoid spreading HIV. And all of those combined in a careful and thoughtful way, oriented towards maximum impact, is the best we're going to do at the current time.
How can someone access your office if they, like you suggest, have need of some help? Is there a special number or a special contact there to help us, crutch us through whatever this issue is that we're not, as you said before?
Well, because we work closely with local health departments, both state and local health departments, and also through community-based organizations, often the easiest way is to work with those organizations in your jurisdiction.
Who are probably already working with you.
They work with us, they have resources, they also understand the issues that people are going through and often can have the most creative results. But we are open to communication at CDC as well, and I would welcome either direct communication to myself. People can call the CDC telephone number and ask to speak with the Division of HIV/AIDS Prevention, and we have someone who can answer questions. We have historically been able to respond directly to some questions and learn a lot from what people bring us as problems that they're experiencing.
Jonathan, you are an amazing person and was so full of energy. I know that it's been said so many times, and I am yet another to say the same.
Great. Thank you very much.
For your help. Yeah.
Great.